Hi, and welcome to the very last lecture of the Value Drug CE trip. I hope you enjoyed these lectures, or at least got a couple pearls out of them. And once again, please feel free to email me if you have any questions. So, the last talk, we're going to talk about some specialty pharmaceuticals that came in the year 2016. Once again, I have no financial conflicts to disclose. And what we're going to talk about some key specialty medications approved by the FDA, talk a little bit about how they're used, their pharmacology, and actually use a case example for some of the key specialty agents we see and talk about some pearls. Just like in the new drug talk, specialty drugs did dominate some of the approvals of the 22 novel new drug approvals in 2016. Approximately half are considered specialty drugs. And one of the things that we do know that specialty pharmacy market is a fast growing segment in our pharmacy today and obviously in the foreseeable future. However, the market's kind of fragmented. You know that sometimes it can be filled at your pharmacy, sometimes you have to go through a specialty pharmacy, and a lot of times this can lead to confusion, patient care management issues with patients, and a lot of times too, we know that specialty drugs are also very expensive, and so affordability becomes a key issue in today and the future. A lot of these specialty medications are approved for rare disease states, and but there are disease states as pharmacists will commonly see, and that is in oncology, hepatitis C, and immunology. And because of that, what I plan to do with this specialty talk is really only focus on a few of the medications that were significant approved or came into the market in 2016 that probably play a role in the everyday care that you would see. And so that's what we're going to focus on for the next set of slides. We had two drugs that were approved in 2016 in the treatment of hepatitis C. And as you know, hepatitis C has been in the news over the last couple of years because it is the treatments that can almost provide a 95 to 99% cure are very costly. So let's talk about hepatitis C for a while since we do have two of the major drugs there. Let's take a look at patient case. MP is a 38-year-old male with hepatitis C. He's reported no symptoms but was tested based on former IV drug use. He has not used drugs for nearly 2 years, and he is told he is genotype 1. His medications include citalopram 20 milligrams a day, lisinopril 5 milligrams a day. He has significant past medical history of depression, hypertension, and allergies. He doesn't have any. We'll come back to our case. So just take a look, go back. Remember, he's genotype 1. He's not used drugs for nearly 2 years. And probably the reason why he did get hepatitis C was based on his former IV drug use. The prevalence of hepatitis C, approximately 3 million individuals in the U.S. are infected with hepatitis C. 170 individuals are infected worldwide. Likely greater based on potential undiagnosed cases. And this is a chronic disease that can be a costly and deadly one. Pathophysiology, we know that this is a viral, so trying to get rid of a virus is a very difficult thing to occur. It is a spherical envelope single-stranded RNA virus. It targets the hepatocyte cells in the liver, and there's varying degrees that it can cause inflammation and hepatic fibrosis and eventually leading to cirrhosis. There's both the acute and chronic phase. Acute is usually a short-term viral infection. Some patients may not even experience symptoms and don't even realize that they are sick. Infectious only for a small window of time. And if the symptoms do present, typically mild, include fatigue and vomiting, and the disease resolves without treatment. And that's why a lot of people go around thinking, oh, I just got the flu, nothing happened, and weren't able to catch it. Chronic, the disease not improve or resolve, and may lead to long-term problems, including liver damage or cancer. The one thing we know about hepatitis C, there are several different types of genotypes, and this is very important when we talk about the selection of what type of drug therapy we want to do. Genotype classification of the virus is based on genetic material and can be even broken down into further subtypes. Genotype 1 is the most common. Approximately 75% of our cases are genotype 1, A or B, and about approximately 25% are genotype 2 or 3. It's helpful to know the genotype for treatment recommendations. The duration of therapy differs based on the genotype, and the different areas of the world have different distributions of the genotype. And obviously, most of these drugs, because of their expense, are not approved without genotype testing. Your classic symptoms of hepatitis C, majority of people, like I said, do not experience symptoms. When they do arrive, they're generally mild flu-like, fatigue, muscle pain, poor appetite, nausea, vomiting, and in severe cases, we can see dark urine and jaundice due to the damage to the liver. Who should be treated? And this has been a very controversial topic over the last couple of years. It should be recommended for all patients with chronic hepatitis C, excluding those with short life expectancies from comorbid conditions. Immediate treatment is assigned the highest priority to individuals, patients that have advanced fibrosis, compensated cirrhosis, liver transplant recipients, severe extrahepatic hepatitis C, and high risk of transmission. As I said, the treatment is controversial. Newer, highly effective oral agents prevent overutilization of healthcare resources. Using these new agents, although they are expensive, may help prevent transplant complications down the road, and they can have an upwards of a 95% cure rate. However, many of these medications have been dubbed the $1,000 a day pills. Only a small number of patients with hepatitis C go on to develop cirrhosis, so therefore, that's the big debate. Do we treat or don't? And there's no way to identify which patients will progress to severe liver disease. Other agents that we use in combination, we have ribavirin and peg interferon. Ribavirin is weight-based. The adverse drug events are severe, not well tolerated, and this is what led to our trying to discover new types of therapy. The other problem with ribavirin is it has a black box warning of hemolytic anemia and birth defects. The other thing is because there's a high risk for resistance, we never recommend this for monotherapy. And remember the way ribavirin's working, it's inhibiting replication of RNA and DNA viruses in our system. When it comes to peg interferon is 100 mic sub-Q once weekly. There's also frequent ADRs with this, such as neutropenia, thrombocytopenia, and it's only approved in combination with ribavirin. And the one thing about it is fewer drug interactions, but it has a very poor adherence due to tolerance. So let's look at our newer agents that have really changed the way we look at treating hepatitis C. Alisio, which was the first one approved in November of 2013, its mechanism is basically it's a protease inhibitor. It was originally approved for genotype 1 in combination with peg interferon and ribavirin, and in November 2014 it was approved in combination with sofosbuvir for patients with genotype 1. It should never be used as monotherapy, and it could cause some photosensitivity reaction, and resistance can be a significant problem. Sovaldi, which was approved in December of 2013, which is a nucleotide analog polymerase inhibitor, is also approved for genotypes 1 and 4, and it was first approved for interferon-free treatment regimen for treatments 2 and 3, and is very well tolerated, and it has a high genetic barrier to resistance. Harvoni, which was approved in October 2014, its mechanism is that it is an NS5A inhibitor, and in combination, it also has sofosbuvir, which is, as we said before, the nucleotide analog. Genotypes, it was originally approved for genotype 1. In November 2015, it was expanded for genotypes 4, 5, and 6 for co-infection with patients with HIV. And in February 2016, it was expanded for use in genotype 1 who are liver transplant recipients. The one thing nice about it, it's a once daily, uncomplicated regimen, and it's very favorable for adherence. Vicirapac, which is a 4-drug combination that contains both an NS5A inhibitor, an NS3/4A protease inhibitor, ritonavir, and dasabuvir. It may be used with or without ribavirin, and it's recommended to use with ribavirin except for 1B without cirrhosis. The genotypes are approved for genotypes 1A and B. In July of 2015, we saw Daclinza, and this was also another SN5A inhibitor, and it was focusing on genotype 3. It can be used also with sofosbuvir, and its recommendation of duration of therapy is 12 weeks. So let's take a look at the newer agents that were approved in 2016. Zepotir, all right, which is elbasavir, and grazoprevir works by 2 mechanisms. It is an NS5A inhibitor and an NS3/4A protease inhibitor. It actually is approved for genotypes 1 through 4, but it's recommended to test for any polymorphism to determine the duration and whether ribavirin needs to be added. And so, like I said, as I said earlier, genotyping is the cornerstone for hepatitis C therapy. It's distinct from early generation protease inhibitors, and it has some activity against some major resistance associated variants. So, in summary, for Zepotir, it's less costly hepatitis C med. It's an alternative to Harvoni, Vicirapac, or Sovaldi, plus Daclinza or Alisio for initial treatment of genotype 1, the most common type form of hep C. All of these options are a clear infection in over 90% of patients. A big difference is that Zepotir costs about $55,000 for a 12-week course compared to $83,000 or more for others, such as Harvoni. But I do want to stress, though, a lot of these costs that I'm giving are just generality costs. And a lot of times what's happening in the industry, and I'm sure during the review session, Greg can speak even more about this, how Value Specialty handles this, is that, there's different pricing, different contracts that are occurring among the specialty pharmacies. Except initial treatment, choice to hinge on factors such as payer coverage, interactions, and if patients have kidney or liver disease. Zepotir and Harvoni may have adherence advantage because they're single tabs taken just once a day with or without food. Sovaldi regimens of Vicira have more pills. Vicira is dosed twice a day. Alisio and Vicira need to be taken with food for adequate absorption. Recommend Zepotir or Vicira in severe renal impairment, and Zepotir on those on dialysis, and avoid others in these cases. Watch for interactions with Zepotir. For example, avoid over 20 milligrams of atorvastatin or 10 milligrams of rosuvastatin during therapy, and reduce accordingly. Epclusa, all right, which has sofosbuvir and velpatasvir, is probably one of the most promising ones that came out in late 2016. It's indicated for treatment of chronic hepatitis C of all genotypes in adults with or without cirrhosis. An option for first-line treatment of any genotype infection without cirrhosis or with compensated cirrhosis or decompensated cirrhosis. Its warnings include bradycardia with amiodarone co-administration. If given with ribavirin, contraindications and warning the drug also applies that ribavirin can cause hemolytic anemia, which can worsen cardiac disease. It does have drug interactions with P-glycoprotein inducers and moderate to potent CYP inducers. Use of Epclusa with these products is not recommended. When we look at the pharmacology of the drug, we have the two agents. The one is the nucleotide analog, the NS5B polymerase inhibitor. The other one is to help prevent viral replication, and that is the NS5A protein. Pharmacokinetic wise, when we look at the two different drugs, it hits max peak effect about in 3 hours. Effect of a high fat meal can affect absorption. And when we look at the way that it's cleared, the sofosbuvir is strongly renally cleared. Drug interactions, that this drug may increase the concentration of DIG, your statin therapies, and so just like some of the other agents, we want to worry about possibly reducing dose. Other drug interactions can occur with antacids, H2 receptor antagonists, and beta blockers, and these may decrease. They may affect the concentration of the velpatasvir in Epclusa. Also, we want to be careful with carbamazepine, phenytoin, phenobarbital. These are all potent inducers, and they may decrease the levels of Epclusa. Some side effects with this drug, fatigue and headache are probably the most common adverse effects. There is no data in pregnant women or in breastfeeding, therefore it should not be done. And like I said, there's a listing of the common effects, mainly headache, fatigue, maybe some nausea. Epclusa is given once daily for 12 weeks in patients without cirrhosis or with compensated cirrhosis, and 12 weeks with ribavirin in patients with decompensated cirrhosis. It is available as a 400 milligram, 100 milligram combination tablet. In terms of prescribing, as I said, depending upon where they are, it's going to be at least a 12-week therapy, and if they're severely decompensated, we might be adding ribavirin. So, the efficacy and safety of Epclusa in patients with chronic HSV infection. When we looked at the trials that were done, there was 4 randomized multi-center phase 3 clinical trials. The primary outcome was sustained virologic response at 12 weeks, and Epclusa resulted in a treatment success rate of over 95%, which is very similar to the other agents prior to it. In terms of what do we monitor, we're monitoring the RNA viral load to see that is it reduced, and also if we're using it in combination with ribavirin, we're checking hemoglobin for the risk of hemolytic anemia. As I said before, in summary, Epclusa is indicated for once daily treatment, so it's good for adherence, and it covers all genotypes. So this one may play a big role in changing what is the first drug of choice. Ribavirin, as I said, we need to monitor because of risk of hemolytic anemia. So, the one thing that we'll be seeing here in 2017 is how much Epclusa gets used. It looks like it's going to further simplify the hepatitis C treatment. It's one daily. It's a 12-week course, and it is still a little bit more pricier compared to Zepotir, but is still significantly lower than Harvoni. So it kind of falls right in the middle between that. It seems to work well as others, and it also, like I said, covers all the genotypes. And so the one thing that'll be interesting is that what will still require and mandate for genotype testing. Probably this still will occur because of the risk of, what if there is resistance. A couple other things that we as pharmacists should be looking at is that obviously Watch for drug interactions. As I said, we may want to lower the doses of statin therapy when in combination with Epiclusa. Also, acid reducers can decrease the absorption of Epiclusa, so discourage using PPIs with Epiclusa because they're going to completely keep the gut more basic than acidic. Suggest taking ACE2 blockers at the same time as Epiclusa or 12 hours apart, and then actually an acid should be spread out 4 hours apart. So that's the treatment regimens. And like I said, Zepatier and Epiclusa, the one advantage of Zepatier possibly could be its cost, but once again, you got to look at which specialty pharmacy and what is being offered in terms of reimbursement. The other is Epiclusa, which that one seems to have being able to cover all genotypes once a day and well tolerated. But when we select our treatment regimen, what should we consider? Obviously, the genotype, history of prior treatment, stage of fibrosis, adverse effect profile, drug interactions, duration, and cost. And so the guidelines basically are given based upon, the different type of genotypes and based upon the type of weeks. And I'm not going to read every individual one. You can take a look at this on your handout. But we're talking about 12 weeks of therapy for all of these agents. And the one thing about that was nice about the Epiclusa that I thought is that you're not really adding the ribavirin unless you have significant decompensated cirrhosis. So, an overview of hepatitis C treatment, just in general. There's a big role we as pharmacists and pharmacies can play. Obviously, taking a lead in education patients, evaluating the numerous interactions that can occur. Suggest testing patients with Hep C risk factors, such as IV drug use, dialysis, or HIV, and everyone born from 1945 to 1965. Recommend tailoring therapy based on Hep C genotypes, the presence of cirrhosis or kidney disease interactions, and payer coverage. Hep C meds are now much easier to manage and better tolerated than older treatments, and new regimens are often all oral and taken for just a few months. And if you compare what hepatitis C treatments, and I can remember working in an AM clinic at Mercy Hospital in the late 90s, most patients did not stay adherent when they were on ribavirin and peg interferon based on the side effects that I talked about earlier in this lecture. Expect most patients to have the genotypes 1 and to usually get 12 to 24 weeks of therapy. Many will use Harvoni or Zepatier. They're once daily and be taken with or without food. But like I said, we have to wait to see what are the advantages of Epiclusa as 2017 moves on. Sovaldi and Vicara regimens are also good options, but remember it takes multiple pills, and Vicara has to be dosed twice a day with food. The other thing that we can help, and this is where specialty pharmacies can play, or working and partnering with like CP Specialty, is they can help address with the patient concerns about assistance programs to help in treatment. Obviously, adherence is so important. The new regimens are over 90% effective. However, adherence plays a key role for this. Also, too, we can help patients manage side effects such as headache, nausea, and fatigue. And to feel comfortable, suggest that they take Tylenol up to 2 grams a day when needed for chronic Hep C patients if they have cirrhosis. So let's take a look at our patient. He drinks alcohol but no cirrhosis, minimal liver fibrosis, has not previously tried or failed other therapies. Treatment is not cost prohibitive for him, does not have renal disease. His viral load is greater than 6 million. So what would we pick? All right. Obviously, the one of the other choices that we may be thinking about is the Epiclusa that is not on this list, but at the same time we may be able to get away with using which agent. So take a minute, take a look at this, and see what you think. Okay. So probably the better choice for this patient could be the Harvoni, but as 2016 approaches, Epiclusa or Zepatier probably may overseed Harvoni, but once again, it still comes down to the patient's payer. Okay? So say you decide to use Harvoni. Do you want to use it in combination with ribavirin? So what do we think about that? Do we think that this patient would actually need to be given with ribavirin? So the patient is without, they're naive, they're without cirrhosis. What do we think? Because they're naive without cirrhosis, probably we could get away without ribavirin. And how long should the treatment be? It obviously is for 12 weeks. All right, so let's change to another type of specialty drug, Taltz. All right, Taltz is actually a humanized IgG4 monoclonal antibody, and it inhibits interleukin 17-8 cytokine. It is used for the treatment of moderate to severe plaque cirrhosis in adults who are candidates for systemic therapy or phototherapy. It is very similar to a lot of our other agents that we use in both RA and psoriasis, and that we have to worry about risk for TB, worry about serious infections. During the time period that somebody's on Taltz, live vaccines should not be administered. And then the other thing too is probably the biggest in terms of side effects is injection site reactions, upper respiratory tract infections, nausea, fungal infections are probably the most common. There's no data in pregnant women to inform on the drug-associated risks, so right now we shouldn't be using it. It's giving us 2 80 milligram sub-Q injections at week 0, followed by 1 80 milligram injection at weeks 2, 4, 6, 8, 10, and 12, and then 1 80 milligram injection every 4 weeks. It's available as an 80 milligram per ml solution for injection in a pre-filled auto-injector or syringe. When we look at the clinical trials with this drug, there were 3 multi-center randomized double-blind placebo-controlled trials. And the 2 studies included an active comparator arm, which subjects were also randomized to receive etanercept 50 milligrams twice daily. And so during the time period of the trial, they looked at changes, and patients treated with Taltz experienced a greater improvement both at the primary endpoints and as well as statistically significant improvements in terms of itchy severity when compared to the etanercept. A couple other notes too, that with this drug is that Taltz is the second approved interleukin 17A inhibitor. Costantix it was approved for plaque psoriasis as well, psoriatic arthritis last year. So it joins a list of several other biologicals indicated for the treatment of psoriasis and seems to be a little bit better selective compared to some of our older agents. A couple other notes I didn't have written on these slides, but like I said, we don't want to give live vaccines and we worry about immune response to other vaccines. So prior to somebody going on any type of therapy like this, as a pharmacist, we should be evaluating what immunizations they would need before going on this therapy. The other thing that we should also, these patients should be getting a TB test before starting therapy, and then counseling them if they would notice any changes in immune response and feeling any type of symptoms of infection. Venclexta is a new oncology specialty drug. It's considered a breakthrough therapy and is indicated for the treatment of chronic lymphocytic leukemia in patients with a 17p deletion as detected by approved test. This indication is approved under accelerated approved based on overall response rate, and continued approval for this indication may be contingent upon verification and description of clinical benefit in the trial. The dosage is on a titration schedule beginning with 20 milligrams, increasing until the disease progression of unacceptable toxicity. There is really no black box warnings with this. When we look at the clinical trials, the result of a phase 2 single-arm study with the primary endpoint showed an overall response rate. Secondary endpoints were the duration of response, progression-free survival, and overall survival rates. When we looked at the estimated progression-free survival and the overall survival, it was at 12 months, were 72% and 86% respectively. Adverse effects occurring in greater than 25% included fatigue, high potassium, hyperkalemia, nausea, hyperphosphatemia, constipation, diarrhea, thrombocytopenia, and upper respiratory infection. So, the last drug that we're going to talk about tonight is Valtossa. Valtossa is a non-absorbed potassium binder and is indicated to treat hyperkalemia. It is dosed by giving 1 packet daily. It does have a black box warning that Valtossa binds to several oral medications, which may affect the effectiveness of the oral agent. Oral medications should be taken 6 hours before or after Valtossa administration. So we have other agents on the market for the treatment of hyperkalemia, but its place in therapy, Valtossa, is for patients who are receiving any type of renin-angiotensin therapy and have hyperkalemia, such as an ACE inhibitor or an angiotensin II blocker. How does it work? It works by a cation exchange polymer that increases fecal potassium excretion through the binding of potassium in the lumen of a gastrointestinal tract, resulting in reduction of serum potassium levels. Clinical application, contraindications, it's known hypersensitivity. It also precautions in hypomagnesium and worsening of GI motility. Black box warnings is that it can bind to many oral administrative medications. As I said before, we need to space it out about 6 hours and choose Valtossa or other oral medications if adequate dosing separation is not possible. Pregnancy, this drug is not absorbed systemically following oral administration, and so there should not be any maternal or fetal risk. Lactation is not absorbed systemically, so it should not appear in breast milk. When we look at the clinical trials, there was a multinational single-blinded initial trial, and it resulted at the end of week 4 that 76% of patients reached target potassium of below 5 and between 3.8. And at the end of phase 1, participants were randomly decided to continue or switch to placebo. The overall results showed the following: is a recurrent hyperkalemia occurred in 91% of patients in the placebo versus 43% in the Valtossa. And so this was giving on a chronic basis. Valtossa, the biggest adverse reactions occurred in greater than 5% of the trial patients were hypokalemic, hypomagnesium, constipation, and diarrhea. Pharmacokinetics, we really don't, because it's not absorbed, distributed, or metabolized, so there really isn't. And it's shown significantly that it does not at all get absorbed. Drug interactions, there's no formal drug interactions outside of the binding and separation of the medication. Common adverse effects, as I said earlier, the hypomagnesium, constipation, and constantly we should be monitoring for hypomagnesium and hypokalemia. In terms of efficacy and monitoring, we should be looking at the serum potassium at least weekly until desired serum potassium target range, and toxic monitoring for serum potassium and magnesium. The way that it's dosed, it's 8.4 grams by mouth daily, and we may titrate greater to 1 week intervals to a max dose of 25.2 grams, administered with food 6 hours apart from oral meds, and we mix the powder with water. And this drug cost somewhere anywhere between $700 to $1,000. So, when would we use this drug for its expense? Well, Valtossa, as I said, is a potassium binder. It's indicated for the treatment of hyperkalemia. It's not to be used as emergency treatment for life-threatening hyperkalemia because of its delayed onset of action. And so a lot of times for life-threatening hyperkalemia, usually what they'll do is they'll do insulin therapy. They'll give them short-acting insulin followed with glucose to prevent hypoglycemia. But what the insulin does, it drives the potassium back into the cells. It does have a black box warning for the binding to other medications, as we mentioned. It comes in 3 different doses and can be adjusted in 1 week intervals. And the most common adverse effects, as I said before, constipation, hypomagnesium, diarrhea, and nausea. So, we already know that we do have one other agent out there, and that's sodium polystyrene, Kayexalate. It's a potassium binder, but one of the issues, it can raise sodium and cause GI side effects. We also know that we have to give this with sorbitol, and it can be very constipating too. Valtossa won't raise sodium since it exchanges with calcium, and it's also not likely to cause hypercalcemia. It may have fewer GI side effects. However, as a specialty drug, it costs $20 a day compared to about $10 a day of sodium polystyrene. And so, when should we use this drug? Well, we should recommend other strategies first before suggesting it, and such as limiting dietary potassium. Can we get dietary potassium? Obviously in our diet, and also avoiding salt substitutes. Recommend a thiazide or loop diuretic for long-term treatment to try to keep potassium lower. If appropriate, suggest backing off meds that raise potassium. And for example, consider suggesting lowering the dose of spironolactone or the ACE or the ARB. And if the ACE and ARB are being used in combination, stop one of them. But the role that this plays is that if we have a patient, like we talked about in one of our earlier lectures, like congestive heart failure, that is on an ACE or ARB and needs it to keep their heart failure under control, or they are on an ACE or an ARB plus an aldosterone antagonist, and the benefits of staying on these outweigh the risk, then this is probably where Valtossa plays a role. Don't recommend potassium binders alone for acute severe hyperkalemia, as I said before, because they don't work quickly. So this was, in terms of specialty medications, just like the new medications, not a big year of significant drugs that impacted the market. However, those 2 drugs we talked about earlier in the lecture in regards to hepatitis C do play a big role, one because of cost and also possible of ease and less complications. When we think about specialty drugs, a lot of us don't get to deal with them every day. I don't get to see them every day. But one of the things that we need to make sure that we stay abreast at are what are those common adverse effects, where does it get used, why is it important to be adherent to these agents so that we can help counsel our patients, especially if we're dealing with programs like Value Specialty that may be sending the medication directly to our pharmacy to give to the patient, or we're dealing with CP Specialty where we have a company that's helping do the clinical in the background, but we are still taking care of this patient. So I hope that these 8 lectures that you were able to get something out of it. I hope that some of this you can apply to your everyday practice. And once again, I want to thank you for having the opportunity for teaching you this way. And please do not hesitate to shoot me an email or send me a phone call if you have any questions. Thank you very much, and have a great vacation. Take care.